Kia ora koutou, no mai haere mai to tonight's webinar. My name is Katie McCulloch. I'm a nurse practitioner working in Tamaki Makaurau. Tonight's webinar is part of the Te Tiri Whakāro Sharing Knowledge series. It's commissioned by Te Whatu Ora to support primary care. This webinar tonight has a dermatology and urgent care focus, so it includes the red face, rosacea versus SLE, and the management of acute burns. And of course, we have our standing segment of clinical updates with Dr. Sue Tutty. Our first session tonight will be on skin with Dr. Paul Jarrett. Paul is a consultant dermatologist working at Te Whatu Ora, Counties Manukau, and at the University of Auckland. He's also an honorary associate professor at the Universities of Auckland and Otago. Thank you very much for joining us tonight, Paul.
Pleasure. Well, it's very kind of you to tune in at 7:30 and welcome from South Auckland. I'm Paul Jarrett, a dermatologist. I'm going to talk about the red face, and I brought this up because it's not uncommon in the clinic to get a referral with somebody with a red face and an elevated ANA, and do they have SLE? So I think to be more accurate, it's rosacea versus cutaneous lupus erythematosus. And I'll come back to this point that you can have cutaneous disease in the absence of SLE, and cutaneous disease can be in advance of developing the full SLE. So a reminder that in skin of colour, erythema can be difficult to detect, and hopefully you can see my mouse here. This lady has diffuse erythema over both cheeks with relative sparing of her nose, and that's rosacea. On the other hand, this lady, again, a European lady, has extensive erythema. It's a bit more extensive compared to the lady with rosacea going onto her eyebrows, but actually, in reality, you can swap them around. So we have the red face, and how will we determine rosacea from cutaneous lupus / SLE? First thing to tell you is that rosacea is very common, and internationally, roughly 5% of the population have this disease. On the other hand, cutaneous lupus is very uncommon, and I'll touch on this paper. So statistically, if you just take a punt, it's going to be rosacea more commonly than cutaneous lupus. But in my final message, I'll return to a learning case for me when I was really young in my SMO career. So a reminder that SLE is systemic lupus. So you can have the skin involvement, and there are three broad types, which I'll show you: acute cutaneous, subacute cutaneous, and discoid lupus. And as I mentioned earlier, these can occur in isolation without any systemic disease, or you can have systemic disease without cutaneous involvement. And there are refining criteria about how to make the diagnosis of systemic disease. But if you're suspicious, consider renal involvement, joint involvement, CNS involvement, serositis, and blood. These are the three broad types of cutaneous lupus. Actually, in the real world, it can be very difficult to hone in on one of these three, and often in the clinic, I'll just call it cutaneous lupus. But this lady on my left has acute cutaneous lupus. This lady has subacute cutaneous lupus, defined by a photosensitive eruption, positive ANA, positive Rho extractable antibodies. And this lady on my far right has the most common form of cutaneous lupus, called chronic discoid lupus, or DLE. So history is very important to differentiate the two. So rosacea often intermittently flares, and those flares can come and go over a very relatively short period of time. Whereas with cutaneous lupus, the redness is often persistent. Rosacea affects women and men equally, but as an autoimmune disease, SLE, cutaneous lupus, more commonly affects women than men. Rosacea is worse with alcohol, and spicy food, they'll flare and flush quite quickly. Whereas with lupus, there is no exacerbation with food. Both disorders can be photosensitive, and by that I mean rosacea can flare in heat and sunlight, but SLE and cutaneous lupus is markedly photosensitive, and often the history will be that it's worse in the summer than the winter. Across the world, the ethnicity is equal. However, certainly in New Zealand, it's more common in Maori and Pacifica patients, and I'll just talk to that again in a moment. Generally, rosacea is in older patients, greater than 30, whereas cutaneous lupus can occur in younger age groups more commonly. Actually, there is an overlap and nothing is definite, but a red face in somebody over 30 is more likely to be rosacea. Rosacea is often symptomatic. It's burning or stinging or uncomfortable. Commonly, but not always, cutaneous lupus is asymptomatic. And rosacea patients are well, barring any other comorbidities, whereas with systemic lupus, they are unwell, usually, with systemic signs. A reminder that in our community in New Zealand, the relative risk of cutaneous lupus in Maori and Pacific is roughly 2.5 times that of the New Zealand population. So ethnicity is important in diagnosing this disease. Ask systemic questions. There is an ocular variant of rosacea that can get gritty and sore eyes, and there is no systemic involvement. You can have ocular rosacea alone, which will be seen by ophthalmology, and facial rosacea in combination with ocular disease. But with SLE, they may be fatigued, and if you do a systems inquiry, arthritis, pleuritic symptoms, ulcers, hair loss, etc., that would point you more in that diagnosis. When you examine the patient, there is central facial erythema, and you can see on this patient there are papules and there are pustules which will come and go. It can be difficult sometimes to differentiate this from rosacea, from acne, but the absence of comedones points to rosacea. With time, there can be telangiectasies and also sebaceous overgrowth and a rhinophyma. And if you look at this gentleman's nose, you can begin to see that sebaceous gland tissue is beginning to enlarge. And actually, it's very simple to treat surgically. On the other hand, cutaneous lupus, there is erythema that can be identical to rosacea. There may or may not be scale. There is an absence of papules and pustules, and you do not see sebaceous hyperplasia as a feature of this disease. If you're thinking about cutaneous lupus, it's worth examining the trunk because it is a photosensitive disorder. And this image you can see subacute cutaneous lupus, these annular erythematous arcuate lesions on the photosensitive areas. And a lesson I learnt many years ago is that actinic damage and cutaneous lupus can look very, very similar. So if you look at the forearms as red and scaling, and the two can be easily confused with each other. So just have those radars going. Remember, actinic damage is far more common than cutaneous lupus, but I have mistaken them myself in the past before getting to the final diagnosis. Check the scalp, and lupus can have diffuse or focal hair loss, so good to check that area. If you're going to investigate it, generally you don't need to do any investigations with rosacea, and they'll be normal: blood clot count, renal function. In SLE, if you have cutaneous lupus and you're worried about SLE, the simple blood tests will help. There may be leukopenia, thrombocytopenia, abnormalities of the renal function, the MSU. The ANA is usually elevated. Extractable nuclear antibodies are detected, ENA, and there'll be inflammatory markers. But really the crux of it is if you've got somebody with a red face and you're going to brainstem mode, and let's just check an ANA, what happens if you think it's rosacea, but the ANA is positive? And the question here is to ask how much weight to put on the ANA in this context with this patient. This paper I found very helpful, and a reminder that in perfectly normal people, the ANA increases with age. So older people, about 1/5 of them will have an elevated ANA, and it means nothing if there's nothing else to support a diagnosis of lupus. If it looks like rosacea and the ANA is a bit elevated, probably it's rosacea. Very rarely, I've taken a skin biopsy, and the histology of cutaneous lupus is common throughout the 3 different types. And there's a lichenoid infiltrate, which is present in cutaneous lupus, but not present in rosacea. And by that, I mean there's inflammation along here, the dermal epidermal border, and around the sweat glands and appendages. And I found that useful on occasions when I need to make a management decision. The treatment of rosacea. To be honest, I'm going off topical antibiotics for antibiotic stewardship. And unfortunately, none of them are funded. But remember to get the patient to apply it to all of the face and not just the red areas, because you want to create a field change. So I have metronidazole, topical ivermectin, which I've just used in a complex patient with rosacea. It worked really well. And then brimomidine, which is an alpha antagonist. If you're going to add a tablet, doxy is quite helpful. We're using it for its anti-inflammatory effect rather than its antibiotic effect. And isotretinoin is a good second-line agent. There are lots of light-based therapies, and as I mentioned, surgery for rhinophyma. So just to finish, this was a learning case for me. This lady came to the clinic with a referral, intermittent redness of the face, what do you think? And the first clue that I missed and subsequently have learned, she was a young person, but of Pacific ethnicity. And if you look here again, it makes a point that in skin of colour, erythema can be very difficult to detect, but there is a faint bilateral erythema. She was completely well, actually. She had no systemic symptoms whatsoever. So I thought, on balance, it's going to be rosacea. So I will treat her for that. And I gave her doxy and metronidazole. And remember, the treatment has to be at least 6 to 8 to 12 weeks to make a difference. And it didn't work. So I gave it a bit longer and it still didn't work. So I checked an ANA. And here this was very useful. This ANA is significantly positive and has a lot of weight in this lady who's Pacifica and young. That is abnormal. So I did do a biopsy in this lady. And actually, you don't want to take a big chunk. So for her, I used a 2mm punch off the central face on the side, just enough. The pathologist moans with 2mm punches. There was enough to confirm it was lichenoid. And this lady had cutaneous lupus, and that changed my management. So in this lady, hydroxychloroquine, for example, would be a good option. And I followed her for a number of years before she left town. And at no point did she get systemic lupus, but I'd be suspicious at some point that may happen in this young woman. So in summary, is it rosacea or is it SLE? Red face with a positive ANA. It's really going back to basics. Take a history. I'd weight age and gender, age over 30, women, ethnicity, Maori or Pacifica, and look for systemic symptoms. In the examination, if there are papules and pustules, that's more likely to be rosacea than cutaneous lupus. Generally, I won't investigate rosacea unless I'm suspicious. But if you're trying to make the differentiation between the two, check the basic bloods, check the renal function, and do the ANA, but weight the ANA in relation to all the other factors in this person. And it becomes, as a scale, say, a balancing act in the end. Thank you. That's it.
Brilliant. Thank you so much for that, Paul. I really appreciate it. A few questions coming in. So how long can we continue doxycycline for rosacea, especially if it's recurring?
My standard is 3 months, so about 12 weeks. I might do it once more, and if you're not winning, move on to something else. And remember, the antibiotics and the topical treatments treat the inflammatory disease. They don't treat the telangiectasias. I don't like prolonged oral antibiotics for anything in these days of antibiotic stewardship.
Yeah, fair enough. On that topic, someone just mentioned the use of azelaic acid recommended for inflammatory rosacea in the British primary care guidelines. Any thoughts of using this as an antibiotic-sparing treatment?
Yeah, I didn't put that in, but there's no reason why you couldn't use that, and actually a topical retinoid as well.
Yeah. Someone's just said here about many people don't like taking an oral antibiotic for rosacea. Can you use 50 milligrams a day of doxycycline or a topical tretinoin? And you mentioned tretinoin in your...
The answer to that is minocycline 50 milligrams once daily is funded on special authority, so that's an alternative option. And for those that don't like antibiotics, low-dose isotretinoin will work really well.
Brilliant. What strength of the ivermectin is used topically?
I'm sorry, I don't know the strength, but it's in the New Zealand formula. I don't know what the tube is, but it's prepared, ready to go. Just rub it on.
Okay, brilliant. And with rosacea, do you use metronidazole and topically and doxycycline at the same time? Can you use them at the same time? Would you?
Yes. If it's mild, I just use a topical treatment and I'm going off topical antibiotics. But yes, I do use both together. And if you get control, I'd stop the doxy, but continue with the topical agent for as long as you need.
Someone's just asking here, but why does rosacea predominate on the face and CLE?
I don't know why the face. DLE, though, because it's a photosensitive disorder, there's a lot of talk about the pathogenesis of rosacea, but why the face? And strangely, you can occasionally get rosacea off the face. I've seen it on the scalp very rarely, and I don't know why it's that area particularly. I'm sorry.
Okay, interesting. Yeah, someone's just asking about the cause of rosacea. Yeah.
Good question. Don't know. There are lots of theories. The Demodex mite is the most disgusting one, those little slug-like things that sit in your hair follicles. And that may be where the ivermectin came from, although actually ivermectin probably affects lipid synthesis.
For ocular rosacea, you mentioned referring to ophthalmology, but how do they manage it?
I'm not an ophthalmologist, but you can use hot compresses to the eyes. That's quite helpful. I think they do use doxycycline as well, but I'm not an expert on ocular rosacea, I'm sorry.
If the rosacea keeps recurring, is it reasonable to then refer to dermatology for ongoing management, or?
Absolutely. We live at Middlemore where we are overwhelmed. So generally we'd manage rosacea virtually. But yes, please refer to dermatology if you're struggling.
How does the hydroxychloroquine work for rosacea? Can you delve into that?
Now I see that now. I'm sorry if I gave that impression. Hydroxychloroquine is very good for cutaneous lupus, and I would not use it for rosacea. And remember, hydroxychloroquine does require ocular monitoring, and there are medical legal difficulties around that unless they're sent off to ophthalmology to get their eyes checked.
If the clinician suspects cutaneous lupus and ANA is positive, what other antibodies should we consider doing, or is it a direct referral to dermatology?
I would encourage referral because often if we see it in the clinic, we'll go to town. So we'll look at all the systems, do all the blood tests, we'll check ANA and ENA, and then treat in the dermatology clinic the skin. We're quite lucky at Middlemore. We do a combined rheumatology and dermatology clinic. So we often manage that with hydroxychloroquine. Methotrexate's a very good agent to use for cutaneous lupus. If it's DLE, that's scarring type, then it is an indication for dermol, clobetasol, to be put on it. You need an ultra-potent steroid. You don't worry about the atrophy because it's a scarring condition. And sun protection, obviously.
Does diet help with managing these conditions?
For rosacea, probably. So if you flush with alcohol or flush with spicy foods, then limiting that will help. I think those that really like that food, probably it's better to let them carry on and treat them. But so diet will help.
Someone's just asking here, what's the main cause of CLS?
Well, I could go on all night, and it's a research interest. And interestingly, we've just done a study with the physicists looking at lipid content in the epidermis, and it's different. And it may be that that lipid affects the inflammatory pathways within the skin, or that the light damages the nucleus, and that leads to extraction of the components of the nucleus, and that's why you get anti-nuclear antibodies. I better stop, otherwise I'll go on all day. It's really interesting, but we don't know. But there are hints. Probably ethnicity is important because it's so common in Maori and Pacifica community. And I did try to do a genetic study, but it proved to be impossible. I'll stop because I'll go on forever.
No, that's really interesting. And can someone just asking about tranexamic use in rosacea?
I'm not personally familiar with that. I know that it's used for post-inflammatory hyperpigmentation, and I'm not familiar with its use in rosacea. Probably that's the only comment I could make about that. Sorry.
Do you get rebound with the use of the brimonidine?
Yes, it can be. And just while we mention rebound, putting a potent topical steroid on rosacea is a cause of rebound. It will suppress it, and then it will flare. And if you're not careful, you go up the steroid ladder and you have topical steroid exacerbated rosacea. And if you pick that up, just wean them down slowly down that topical steroid ladder with a bit of doxy. Otherwise, it's terrible for them while they settle.
If the rosacea recurs after 3 months of doxycycline, can you use doxy long term, or do we switch treatments? I know that you're trying to move away from the oral antibiotics, but
yes, I would switch. I'm not comfortable about using long-term oral antibiotics. So if you're not winning, then my next step would personally go to isotretinoin, sort of low dose, give that a whirl, the lowest dose that they'll tolerate and keep the symptoms at bay. And interestingly, the isotretinoin lecture we did a few months ago, using it intermittently on a PRN, it's very flexible. So that will be my next option. And then if that will treat the inflammation, but the telangiectasias, often it needs some light-based therapy to treat it.
Do you often use light-based therapy alongside antibiotic use or topical use, or?
You can. There is evidence about its inflammatory, anti-inflammatory properties, but it's quite expensive and it's not funded in the public system. So my own view is to use funded treatments first to see where you get to, and then discuss the options with the patient. And if they choose to go and pay for it, well, good on them. That is an option that they could take.
Is it IPL or red light therapy, or?
All of it.
All of it. Right. So people could use those at-home masks?
Now you're talking to a medical dermatologist who does no cosmetics, and I'd be a bit angsty about using home-based masks. I think I'd want to go to somebody that knows what they're doing. Absolutely. And a reminder that doxy is photosensitizing, so using the two would be a bad move.
Yeah. Okay, interesting. How long does it take for the isotretinoin to work usually, and how long do you continue the isotretinoin?
Often I'd start with about a 3-month treatment course, the lowest dose that they tolerate, and see where you get to, rather than a full acne vulgaris course, and then stop. And remember that it has that hangover effect for a while. And some people, one treatment is all they need, but others, of course, their tolerance of the redness diminishes when it goes away. They often need intermittent treatment, but I'm more comfortable about using isotretinoin long term than oral antibiotics.
If there's a strong family history of SLE, does someone have a higher chance of getting it? Should you suspect SLE in a young person, non-Māori Pacific ethnicity, with bilateral cheek flushing and a strong family history of the condition?
Yes, rarely. It's not common, but I have seen mums or dads and their children get it. I've seen sisters with it as well, but it's uncommon. But the genetics are important. So that again would raise your radar about investigating them a bit further, definitely.
Can you tell us your dose for low dose isotretinoin in this situation?
It's the lowest dose that works and they tolerate. So you can get it in 5 and 10 milligrams. I never go beyond 30. So if it's an older person in their 30s or 40s, they don't tolerate isotretinoin very well. So I'd start low, perhaps 5 or 10 milligrams a day, and see how you get on. And it may take perhaps a month to 6 weeks before you begin to see some improvement. But if you overdose them, the side effects are too troublesome, they'll just get rid of the drug. So go low and slow would be my advice.
And with PRN use of doxycycline, how many days do you recommend?
I wouldn't use PRN. I would use it for a course, and it's either worked or not worked, and then stop it. Using it itty bitty, I would not recommend.
Yeah, okay. And that would be a 3-month course.
Yes, I mean, normally 8 to 12 weeks would be the length of time I'd embark on a course of doxy.
And just nipping back to the light therapy, does it help with the pustules as well as other symptoms? Or?
There is evidence that it will, actually, yes.
Awesome. That's great. Well, that's all we have time for with our Q&A. We're due for our next session, but I just want to say thank you so much for joining us tonight, Paul.
Pleasure.
Really appreciate it. It's really interesting. Thank you. So our next session tonight is with Dr. Guy Melrose on the management of burns. Guy is an urgent care physician who works clinically in Tauranga, and he's the Director of Professional Development for the Royal New Zealand College of Urgent Care. He's also a Professional Teaching Fellow at the University of Auckland, within both the Department of General Practice and Primary Care and the Department of Anesthesiology. Thank you so much for joining us tonight, Guy. Really appreciate it.
So, kia ora koutou, and thank you, Katie, for inviting me back. I apologise if people are getting fed up of seeing my face, but I do enjoy having the opportunity to speak to the primary care world out there about topics relating to urgent care. And for this session, Katie asked about burns. And first up, I'm an urgent care physician. I'm not a burns specialist. And in 15 minutes, I don't think we can cover everything. So my approach tonight is kind of drawing on my philosophy of primary care CPD, which is analogous in my mind to a pilot flying an aeroplane, having the memory items that they have to recall straight away off the top of their head, contrasted with the quick reference guides that they look up to guide them for the deeper knowledge that they need to operate a complex entity like an aeroplane. So I think for us, we need to have some certain items that we consider memory items that we should all know off the top of our head. And that's my focus tonight, and also to guide you to the right guides to help us manage the sorts of burns that come through primary care, acknowledging that whilst serious burns do come through, the main trauma and serious burns are likely to bypass us. So this is more focused on the sort of burns that we will see. So with that in mind, these are my quick objectives to try and get through. I want to talk briefly about the National Regional Burn Centre referral guides, a quick point of the important historical factors that we should consider, the examination findings that we should be looking for, a little bit on note keeping, a few things that we should be extra aware of in the community, and then we'll touch on blisters and dressings at the end. So the National Burn Service guidelines, if you take nothing else from tonight, it should be these. The National Burn Service is based in Middlemore Hospital, and they cover the entire country for all the serious burn management. That's where they're based. But there's also 4 regional units. The Auckland and Northland unit is also based in Middlemore. And then Waikato Hospital covers Waikato, Taranaki, some of the central North Island and up into Gisborne. And then Hutt Hospital covers the rest of Hawke's Bay and rest of the North Island and a bit of the South Island, and then Christchurch, the rest of the South Island. So there are 4 regional units, and it's important that you know which unit covers your particular location, and all the information you can find at the website nationalburnservice.co.nz. And they've got a set of guidelines which are very useful to follow, and the one I'm referring to tonight is the initial assessment and management of burn injuries, which I would recommend you all look at. I didn't want to just take from it and put up slides with that, so I prefer you all to just take a moment to actually go to the website and look at the documents yourself. But these will really help you with doing your initial assessment. They'll tell you who to call and when. It very clearly states the referral criteria for the National Burn Centre and for the regional burn centres, which the regional ones are going to be the ones we're most likely to be speaking to from an urgent care and primary care setting. There's management advice there, and there's a really nice flowchart that takes you through the first 10 days and is really easy to follow. So this is the front page of it. That's the only bit I've taken from it, but as you can see there, it's got a number of things there. Some of it is things like fluid resuscitation is definitely maybe more in the ED realm, but you may find yourself dealing with a more severe burn in the initial stages. So it's good to have on hand. So being aware of that now, these are points that I've pulled from that, and also just my experience over the years of some of the historical things that we should be asking, kind of, as I say, as a memory item off the top of the head. And it's difficult taking a history, partly because these are often children and they're screaming, and often patients are quite distressed, and it's quite an uncomfortable thing. So we need to get these sorts of information to the front when deciding which of the pathways to follow there on the guideline. So we need to know what has caused the burn, which sounds obvious, but is it a dry fire burn? Is it a wet scald? Were there chemicals involved, and what chemicals were they? Was it an electrical burn? If so, what's the voltage? What was the occurrence of how it happened? Then time is important. We need to know when the burn happened, how long the person was in contact with whatever's causing the burn. And it's also important to know things like how long was it from the point of burn to the time that some recognized first aid was applied. So generally that's running under cold water. So the time that it was from the burn to that is actually important. And then what first aid has been applied. And this is not just, is it recognized first aid? Some people do things like getting ice and things that are not recommended, but they do it in a panic. So it's important to know, what have they applied to this? Have they tried some kind of burn gel? If they have used first aid, what have they used? When did they use it? And for how long did they use it for? Very important with the water, because sometimes a patient might say, yes, I've run it under cold water, but if they've only done it for 5 minutes, then you need to then start again and do further in your clinic. Risk of inhalation is a really important factor to determine, because that's one of the referral criteria. So in the history, we can gather that information from knowing what caused this, but were they in an enclosed space? Were there gases present? Was it explosive? And certainly the two inhaled burns I've seen through my clinic have been aerosol canisters that exploded on like a pot fire kind of thing. I've put here, do not forget ingestion, and that's really just to remember that caustic things that might burn the skin or might burn the eye will also burn the inside. So if somebody has ingested a caustic agent, then that's very important to not forget. And so if there's been somebody splashed in the face with it, you might be looking at eyes and face, which is very important, but don't forget they could have ingested it. A little point on non-accidental injury. The history is a good time to start asking the questions to raise those sorts of things. So has there been a delay between the child being burned and their presentation? Is the history inconsistent with what you're seeing and the distribution and the pattern of burns? Do they not fit? Is there something within the personal interactions that are making you feel a little bit iffy? So always remember NAI. Tetanus is important to establish so that you can update that as necessary. And then the relevant past medical history for burns are things like diabetes, peripheral vascular disease, and also if people have peripheral neuropathy, there's lots of stories of people having hot water bottles burn them, or their feet too close to the fire, just because they can't actually feel the sensation of being burned. So that's an important thing. Moving on to the examination, ABCs are always important, and sometimes we maybe forget that, and it's easy to do if someone's just touched a hot plate, but always remember ABCs, and then move on to the location to establish exactly where they've been burned. And the reason I think it's important to make that a careful step is that if somebody particularly has been scalded and they may have a really sore part of their body and will distract you towards looking at that, but actually there could have been burns elsewhere. So you've got to check, particularly in kids, but adults as well. Remove clothing to check the skin. Don't be led just by where they're telling you it's sore. Make sure you've checked everywhere. And it's important then, once you've established everywhere that's been burned, that you try and estimate the total body surface area for everywhere that is burned above just simple epidermal burns. There's the Lund Browder charts. There's also the patient's palm roughly equates to 1% of their body area. I find it quite difficult to do, and I'm just going to give a shout out to my colleague David Sorrell, our Director of Clinical Training, because he told me about my top tip at the bottom there is the New South Wales Trauma app. And this is an app that includes a New Zealand section, and whilst it focuses on trauma, there is also a burns section. And he said there's a really good thing within this that you can get a model of a human, and you can draw on there where they've been burned, and it will help you calculate the percentage burn. So I've yet to try that out, but Dave swears by it. And when I reviewed the health pathways, they actually mentioned it in that as well. So that's a top tip for you to look at. I believe it's free you have to sign up, but it's free to join. Then it's very important to make a mental note when you're examining. Are the joints involved? Is the face involved? The genitals, hands, feet, perineum. So these are all important things to find on your examination. And between what I've mentioned here and in the history, with pretty much that alone, you will be able to determine, do they meet the referral criteria based on the Burns Centre guidelines. So the two, as I mentioned, is national burns, which are for the really serious ones, but the regional burns referral include any burns to special areas like face, hands, feet, and perineum, any electrical burns, any chemical burns, burns in kids who are under 2 or anyone who's over 70. And these are a phone call usually to the burns service. It doesn't mean shipping the patient off to be seen, but it means involving them for advice. So hopefully by the end of history and examination, you should be in a position to make a call as needed. Which brings me on to the note keeping. And this is something that's very important, because when we are dealing with burns, it is a 10-day process really, and longer, but the follow-up and management afterwards is so important. And so if you're the person on day one, it's very important that you've asked those questions that I mentioned, do the examination as mentioned, and to make sure that you are documenting that clearly, along with photos, which are very helpful, or diagrams, and any treatment that's done and any follow-up that's done. And the reason for that is that when the person is reviewed, it's really useful to have it logically written down and in order. And if you're not the person reviewing them, if they're going off to a dressing clinic or back to their GP, then it's really useful for that person reviewing them to have a decent copy of your notes. I just remembered I skipped through after the TBSA there in the examination, the depth. There's a chart within the guidelines that very easily helps you determine what is epidermal, what is superficial dermal, mid-dermal, deep dermal, based on the color. Are there blisters present? What's the cap refill and what's the sensation? So if you simply just check, note the color, are there blisters, what's the cap refill doing, and what's the sensation? Again, if over the phone, someone will probably be able to tell you what depth that burn is if you're unsure. Oh, sorry, I skipped forward. So yeah, note keeping very important, and because burns do change on review, and you do find that deeper burns become more apparent. So it's important to know what was seen earlier and what the treatments were. So in my Be Aware section, circumferential burns are important. They are one of the referral criteria. Circumferential burns of limbs and the chest. We're most likely probably in an urgent care and primary care setting to see people who have dunked their hand in some hot oil or hot water or something, and the burn will be all around the joints, all around the digits and the wrist, for example, and that does pose a risk to function depending on how that heals. So it's important to make sure that you look for and note, is this burn going all the way around? Inhalational burns, again, that is a referral criteria. And I mention this just because there's two cases that I've sent into hospital after discussion with the burn service, because they, as I mentioned, had the explosion from a canister, an aerosol canister, and they looked fine, but they had singeing of the nostril hairs, they had singeing of their eyebrows, and that's one of the signs we need to look out for some hot gas of some kind going up into the airway. Snot that is sooty coloured is also a sign you might see, and obviously blistering and redness to the face. Late stages of inhalational burns, people get tachypneic and they get laryngeal swelling and their voice can change, and really by that time you're in you're really struggling and in a bad place. So if you've got a suspicion of inhalational burns, definitely, as per the criteria, speak to the burn specialists. And it's probably like in my cases, they didn't develop anything, but it was much better that they were in a place where if they did, they could be managed properly. So have a very close look based on your history around the face for signs of that. I've mentioned prolonged contact and trauma. Burns associated with trauma are also something we should call burn service for. And I've mentioned prolonged contact because we quite commonly, particularly around Waikato, will see a farmer who comes off a farm bike and gets pinned with their leg against a hot exhaust, and there's a little bit of time before that gets lifted off. And so any person who gets trapped against something hot, or there's prolonged exposure to something, there's more likely to be a deeper injury there. So just be wary of that prolonged contact and any trauma associated. And I've mentioned eyes as well, because you do see burns of the eyes, caustic stuff goes in the eye, and eye specialists obviously need to be involved there. You irrigate the eye until their pH is normal, and then fluorescein will reveal any damage. But obviously eye people will need to be involved with that, and burns service for the rest. So don't forget the eyes is the key thing. So the question, do you de-roof blisters or not? This has been a question that's been bounced around many times. The general feeling, it seems, from pathways and the burn service is, if they're small, you can leave them, but if they're large and tense, then you de-roof them. And it's a very satisfying thing to do. You cut the blister open and cut away the dead skin, and the debriding over the joints is the thing that I've not had to do, mainly because if there's a significant burn over a joint and it needs something debrided, then that's probably one you'll be speaking to a specialist about, because that's probably a bit beyond us. But blisters are something that we can definitely de-roof in the urgent care and general practice setting. And a quick note there, if you're doing that prior to them being transported, the guideline does say they must be dressed for transport. I'm not sure why we wouldn't dress them, but they've put it on there, so it must be something that we forget to do. So, so I've mentioned that there. And talking of dressings, epidermal burns really just need moisturizing. But once they are superficial and beyond, then we need to be putting something on. And it varies. The health pathways for superficial have recommended things like Mepitel, Cutiserin, Gelinet, some non-adherent and sterile dressing. But the burns guidelines would lump the superficial and the mid to deep dermal in with the antimicrobial dressings. And these are things like Acticoat, Mepilex, AG, things that have got silver in them. And I've put a little star there saying, if possible, because ultimately the availability of these depends on cost, and they're not always available. So Mepitel Cutiserin that you may have is certainly better than any other dressing if you don't have silver impregnated dressings. And that's why at the bottom, the follow-up know your services is important, because knowing which burn services or which dressing services you can refer to is also useful. And also having nurses who are specialized in burns to come to your clinic and do some CME for your nurses is really important as well. And then they can talk about what you should maybe be stocking depending on what you're seeing. But the key point is SSD cream, the silver sulfadiazine cream, flamazine, shouldn't be used. And that's something that was used a lot for burns, but that's been well shown to delay healing. So definitely don't use that. If you take anything from today, throw that out. Cling film, though, is useful to have as a transport medium. So keeping some of that in your clinic is useful. So the summary really is, if you take a good history and a good exam, then referring to these guidelines, you should be able to determine the depth, the body surface area, and whether or not a referral, a phone call to the burns unit, your regional one or the national one, is appropriate. And through email and pictures and a phone call, they can guide you very, very well, and the management from there on. And as long as you do careful notes and complete notes, then the chain of follow-up is maintained, and hopefully continuing to follow that those pathways beyond, referring if people sort of deteriorate or new things come to the head. And if in doubt, always call. I find they're a very friendly service, and you can find more details at that website. These were my references. That was the document that I followed. The Cochrane database back in 2013 was, even back then, was saying that we shouldn't be using SSD cream, which I think is interesting because it was certainly being used back then. And the regional pathways burn injuries is good. And the obligatory plug for our college podcast if you want weekly CPD. Otherwise, thank you very much.
Brilliant. Thank you so much, Guy. I really appreciated that. We've got questions coming in just around the de-roofing of blisters and what tools you use. Sterile needles, small blade. What do you tend to use to do that with?
Sterility burns are sterile generally when they happen, unless they're very heavily contaminated. And so I read in one of these guidelines that it talks about the use of antibiotics in the not being needed if the burn is sterile. So if we're then popping a blister and opening it up, then it's important to maintain sterility. So what I would use is a dressing pack with the sterile drape, and don gloves, and I tend to use the sterile, the nice fine scissors from a dressing, a suture pack if needed, or sometimes they're autoclaved separately, but I like the nice sharp ones, and a pair of forceps. You can scalpel to open it up as well. And then once you've got that little window, you can cut around. If you go slow and gentle, it's it's like cutting someone's hair. They're not going to feel it. The difficulty is if you touch the raw bit underneath, that's going to make people upset. But the last time I did it, it was a little girl who had been screaming her head off, and she sat very carefully when that was done. I had a chat, as I said before, Dave Sorrell, who's interested in burns, so I ran things past him, and he talked about how there was a period of time where people would aspirate to sort of take the pressure off. So you're just sticking a needle in and aspirating with a syringe. And he said that's not something he does anymore or recommends anymore, because once you're removing that fluid, you may as well remove what is effectively dead skin, that blister, away, and then get a nice silver dressing on there as a kind of as an antibacterial nice dressing, rather than doing a half-hearted job where you've potentially introduced some bugs and then left all that sloppy tissue on top. So if anyone has done that in the past, it's probably best to not do it. But if they're small, you leave them. But if they're big and tense, then really they're better to take off. And they do evolve also, and that's why the follow-up I mentioned is so important, because burns that look like they're sort of mid-dermal might actually be deeper when you review them later on. Things sort of evolve over time. So that's I think I've covered that.
How often do you review and change the dressings?
Again, the flow chart on the back of the guide, where is it? One of these. It's 12 pages long. This, so it's quite there's quite a good. I've got missing. There's a good flow chart on the back, and they have a day 3 assessment, which is about the right sort of time. So between, I think, Pathway says 2 days, 2 to 3 days is a good time to do that reassessment, because at the day 3 reassessment, you're then rechecking certain things. Has the burns progressed in depth, in which case you refer. If there's absorbing lots of exudate, then you can start to put something that a dressing that absorbs on. So day 3, and then day 10 again is the sort of the final decision. So it's every 3 to 5 days up until that point where you've ascertained that it's either not healing at day 10 and is probably needing some specialist input, or they've healed up. So as I say, it's on page 10 of the guidelines. It's a nice flow chart to follow. So that's what I would follow.
Okay, and in terms of pain management for those dressing changes, or I mean, I guess again it depends on the burn, but do you send them home with any pain relief?
Yeah, so it's one of those things with burns, is the more superficial, the more painful they are, and the deeper they go, they become less painful because you've knocked off all the nerve endings. So certainly in the initial phases, when they're really sore, that's almost a good sign. Pain relief, oral pain relief, Pamol and ibuprofen for kids is usually enough, to be honest with you, because once you've then got the dressing, you've cooled it, and then you've got the dressing on. That I find makes a huge difference, and the kids are much more settled. Adults, whatever you would usually use for for any injury. Dressing changes, the ideal would be you're not putting something on that adheres. So these various things I forgot to mention, another one Dave mentioned to me was something called Bactigra, which is a paraffin impregnated dressing that's also got some chlorhexidine on. So it's a different one to the silver impregnated, but he's used that before when from availability or whatever's there. But all of them are these silicone non-adherent things. So hopefully they should lift off relatively easily, and you don't want to be sticking down the sore bits. Anything you use to adhere the dressings should be well away from the sore area. But before any dressing change, pre-dosing with pain relief if they're expecting it to be sore. And I guess Entonox could be used, but I'd be a bit worried if someone was really that sore as to, is it getting infected? Is there another, is there a problem developing there? But yeah, go slow and steady, I think it wins the race. And I should probably say that actually the real experts in a lot of the wound world are our nurses. And so in all the clinics I've worked in, I do the assessment, and then I'm very much working in tandem with the senior nurses, and they're the people who do a lot of the CME in that area and do a lot of that kind of keeping up with all the latest available tricks and things. So it's very important to, if you're, I'm aware that the audience is very different, but to the medics in the audience, definitely work in tandem with the nurses, and I generally follow their guidance, if I'm being totally honest with you.
Someone's just talking about over-the-counter sort of Weleda burning cooling gel, aero burn spray, calamine lotion. Are they useful in superficial burns?
So the epidermal burn, so that is just an area of redness, but there's no damage to the skin and there's normal cap refill, normal sensation. Those generally you leave just with any kind of moisturizing cream. So I guess whatever you have. Chatting with Dave, he did mention that those burn sort of gels are probably not the ideal thing for people to be putting on. And what you're wanting is the recognized first aid is 20 minutes of cool running water between 8 to 25 degrees, aiming for about 15 ideally, and should be really applied within the first 3 hours of the burn injury. So after 3 hours, it's kind of done, because you're wanting to remove the heat. It makes me feel a bit icky thinking of steak cooking on a griddle, but once you've removed it from the griddle, it still cooks unless you literally shove it in a freezer. So the same happens with our body after a burn. You've got to remove that heat, and the running water literally takes that heat away. But you don't want to go too cold because you don't want to constrict those blood vessels. So that's why ice is not used, and so it's running water of as I say, about 15 degrees is ideal, and that's the best thing for people to be using. And if it's large body surfaces, then presumably St. John is probably the people you're waiting on, but you've got to avoid hypothermia and the like. So the over-the-counter burn things are probably, the cooling gels probably not as good as water, and then into a clinic to get a professionally put on dressing and follow up.
Brilliant. Thank you so much, Guy. I really appreciate your time tonight. We now have our standing segment of clinical updates with Dr. Sue Tutty.
Thank you, Katie. Great. So I wanted to start tonight by talking about, there's a couple of things from Pathways that have been clinical updates onto the pathway. And so I wanted to share those with you. The first one is about measles, and it's some additional advice that's been put on there to follow up anyone presenting with a measles-like illness, right? So anyone presenting with a measles-like illness, if you suspect measles, what they wanted to make the point of is that it's really important that you isolate the person immediately, that you do not send them to the laboratory for testing, because obviously that's going to increase their exposure. So what we want you to do is either send them back to their car or put them into a room that you've got in your practice. And you will need to perform the PCR testing yourself. And the advice is that if we're wanting to manage measles better, that we need to concentrate on our vaccinations, and also to offer vaccinations to children who are between 4 months and 12 months if they are travelling overseas, so that they can be covered while they're travelling. And then when they come back to New Zealand, they will still need a 12-month immunisation. So it doesn't replace it, it's just an additional vaccine. Okay, and just to remind you of the signs and symptoms of measles, it's the maculopapular rash that starts on the neck behind the ears and spreads onto the trunk and then the limbs. There's usually a high fever, so over 38 degrees. There's the cough and the runny nose, but also conjunctivitis is often seen with measles, and the Koplik spots, which occur usually a couple of days before the rash. And by the time the rash comes out, the spots are starting to look a bit sloughy and ulcerated a little bit. They're white spots seen inside the cheeks, and they're there in 50 to 70% of measles cases. So if you see the Koplik spots, you can be fairly sure that you've got the right diagnosis. So then inform public health and isolate the child. And if you are taking the swab, then it's that nasopharyngeal swab that we're so used to, that is the preferred option, or if you have to, a throat swab. And that's anywhere from day 0, which is the first day of the rash, until day 7. The other clinical editor note that has been put up is one about denosumab, which is a treatment for osteoporosis, Prolia or Xgeva. And the special authority criteria for this was changed in the 1st of March to widen it. However, even though a general practitioner can prescribe this, you may want to seek a specialist advice or review. I've got a patient on this medication as well, and managing his calcium after his injection has proven quite difficult, so I've appreciated the specialist advice on that. This is a subcutaneous injection that's given every 6 months, but the biggest concern with this medication is that if you miss a dose by more than a few months, or if you decide to stop it, that there have been reports of clusters of spinal fractures occurring within a few months of stopping. So if you are going to prescribe this and start a patient on it, you need to be really sure about a plan of when it will be stopped and how it will be stopped, how you will manage stopping it. And the last good news story in this section is for contraception for Mirena. We have been saying for some time now that Mirena is being used for 8 years overseas, but we can now use it for 8 years in New Zealand without having to do a Section 29, which is having to advise the patient that it is off license, because it is now licensed for 8 years in New Zealand. If you're wanting to use it for endometrial protection, however, you still need to replace the Mirena at 5 years. And if you're using it to treat menorrhagia, you can leave it in for up to the 8 years if the symptoms are still well treated. But if the symptoms start to return between the 5 and 8 years, then you may need to replace it before that. And the section is on Pharmac, and this is released today, that there are changes to the regulatory and funding restrictions placed on ADHD stimulant medications. So this isn't going to start though until the 1st of February 2026, which gives us plenty of time to look at how we treat ADHD and how we make the diagnosis, because from the 1st of February, we can do that in general practice and start people over 18 and over on this medication. So the reason for delaying it is both allowing that time for the education, but to get over the supply issues that I've been talking about for about the last few months in these sessions. And also it's anticipated that there will be extra demand on these medications once primary care is able to prescribe them, because it's been recognised that that has been a block to people being able to access this care. So this is the changes that we're seeing on MedSafe. So for people with ADHD aged 18 years and over, medical practitioners specialised in paediatric psychiatry and general practice has been added, can prescribe these, and also to nurse practitioners working within this area of practice. And a change has been made for people with ADHD aged 17 years and under to include nurse practitioners working within paediatric services or child and adolescent mental health services to prescribe the stimulants. Another Pharmac change is with estradiol patches, and I know a lot of people have been concerned about the access to estradiol and Estradot, and both these brands will be available from the 1st of December, subject to their availability, because they're all also in short supply. The other listed brands will be available until the end of November. So it's just giving time for that transition. And the limitations on supply will on dispensing rules, and patch limits will stay the same with 1 month supply at a time and only 2 patches per week for each strength. So just that we'll have that additional brand. Dulaglutide, good news here again too, that the no new patients restriction will be removed from the 1st of July, so from next week, which is great. I've put a little bit of the history into this because it becomes relevant with my next slide. So in, I think that's September, it was recognised that there was going to be a shortage of supply in 2022. In March 23, Pharmac acted to add liraglutide as another option for us to prescribe. But the shortage got worse again, so they restricted the access to those who had tried other treatment options. And then from May 2024, we still didn't have enough supply, so no new people were able to be added. And this is the restriction that has been taken off now. So that restriction about having tried other medications prior to using dulaglutide still remains. And I've put on here the special authorities, and it's got the difference here between empagliflozin and dulaglutide in this criteria. And that with empagliflozin, as you know, you just have to have tried 1 glucose lowering agent, but to prescribe dulaglutide, you need to have tried all 3 of empagliflozin, metformin, and vildagliptin. So when these products were first available on the market, these special authorities were the same, but it was shortage of supply that led to that difference. And this is just the rest of the special authority, which I'm sure you're all well aware of. And I've done just a quick comparison of dulaglutide and liraglutide, which is the other medication that was funded when there was a shortage of supply, and with its trade name of Victoza. So the dulaglutide's once a week, whereas liraglutide's once a day. They're both for diabetes management, but a form of liraglutide is used for weight loss as well. Dulaglutide is a 1 pre-filled pen once a week, comes with its own needles, and then it's disposed of, whereas the liraglutide has the pre-filled pen that contains multiple doses, and you need to prescribe needles for it. And I've just put in that dose escalation schedule. Liraglutide has the advantage that you can gradually increase the dose, which sometimes helps with the nausea that's associated with this drug. Macrogol I talked about last month, that it's another product that's in short supply, and to try and prioritize it for people with who are taking clozapine, because I'm sure you're all aware of the problems that they have with constipation. And the difference I wanted to just point out today is that the discovery that the alternative brand that can be prescribed under Section 29 does contain gluten, so just to make you aware of that. And then in my last section, looking forward, I want to talk tonight about CKM disease, which is cardiovascular kidney metabolic disease. Now, this section is always talking about things that others are talking about, I guess, in primary care, about things that aren't with us at the moment, but are under discussion and what might be coming. It is not current practice at the moment. So looking at manifestations of CKM disease, you can see that it considers a blood pressure of 130/80, which is a bit different to what we've usually been working with. And it has that hemoglobin A1C of 48, which is something we've talked about before in this section as something that is getting more and more discussed more and more, although it hasn't become accepted practice at this point in time. And then we've got dyslipidemia, cardiovascular disease, the sort of things that we're used to talking about in terms of cardiovascular risk management. Chronic kidney disease, though, is getting more, being talked about more. Metabolic dysfunction, gout, and obstructive sleep apnea. So the thought is that the main role of cardiovascular risk assessment will be now to screen for CKM disease as well. So it's widening the concept of that screening. So on the left side, I've put most of the things that we're already aware of in terms of high cardiovascular risk. And on the right have included some of those more kidney-related conditions that we're being asked to start thinking about a little bit more. So urinary albumin creatinine ratio of greater than 30 and eGFR of less than 45, etc. And the management, new thresholds, we're looking at blood pressure control at a lower point, so being aggressive with blood pressure control earlier, and trying to treat down to 120 to 130 rather than just getting them below that treatment level of 140. But at the same time, taking in clinical complexity and considering the patient. And obesity, they're talking about preclinical obesity, clinical obesity with CKM disease and clinical obesity with non-CKM disease. So going forward, if you want to hear more about this, there's the pathways, Health Pathways produced a webinar on CKD, chronic kidney disease, on the 17th of June, which will be available on the Pathways soon. If you want to learn more about CKM, there's a website there. And if you're wanting to give feedback on any of this information, because as I've said, it's only being discussed, it's not clinical practice at this point, then probably your best way is to go back to your PHOs. So thank you. Any questions?
Yes, brilliant. Thank you so much. So I'm very mindful of the time, so we just have a couple of quick questions regarding measles. So if patients present on telehealth over the weekend and their GPs are closed, do we have any good suggestions as to where they should go and get swabbed or checked out?
The most important thing is that they clearly identify that there are possible measles risk before they don't go into any practice, but they let the practice know so that someone could come out and see them in the car.
In terms of advising family members, if exposed, are the family members also isolated with measles?
Measles is reasonably infectious. I would need to go to the pathway and check on what the isolation policy is.
Brilliant. Thank you so much. That's all we have time for tonight. I just want to really reiterate to each of our 3 speakers tonight that the topics were super interesting, and I really appreciated your time. I really appreciated everyone's time for joining us tonight. Have a lovely night, everyone. Ka kite.